This conference will now be recorded.
Good afternoon, everyone, and welcome to the kickoff webinar for the Flex webinar series, Renewable Health Value. This is Sally Buck, CEO at the National Rural Health Resource Center. And just a reminder, your lines are muted. You can start to unmute your line as we're recording the call. And we'll get started with today's session. The Rural Health Resource Center serves as the Technical Assistance Service Center for the National Rural Hospital Flexibility Program. And as the nation's leading technical assistance and knowledge center in rural health, we do focus on 5 areas, and these do flow out through the Flex program also: performance improvement, health information technology, recruitment and retention, community health assessments, and networking. And we try to integrate all of these areas throughout Flex, as well as through the other programs that we work with throughout the United States with state offices, hospital associations, hospitals, and networks. And the webinar series objective, before I dive into that, just a reminder that we are doing the webinar series in place of the face-to-face conference that we generally held in the summer each year, and we are sorry we won't be able to see all of you face-to-face at a specific Flex conference. So we're put together a format, a series of webinars, and it is quite a few. We have added up the learning sessions do equal 11 hours of content, but that compares to about a day and a half, which is what our conferences have been. So if you compare it to that, but realize that you don't have that travel time and you can be in the comfort of your own office or cubicle, and we will definitely be connecting together through other events such as regional NOSOR meetings and the NRHA Critical Access Hospital Conference, where we'll be doing a grant writing workshop for Flex the day before. So our objectives through this series is to explore how the core areas of the Flex program can be supported by performance frameworks in the emerging value-based healthcare system, and to look for examples of Flex-supported activities that align with the performance excellence frameworks. We will also get an understanding of Flex program-supported interventions for financially distressed cause on the verge of closure. And also, through this series, it will expand your awareness and use of resources targeted to support Flex programs in their critical access hospitals. So through this series, we gathered together great speakers with some state examples. Critical access hospital leaders will share their stories and best practices, and we also will be using an online course format to accompany the smaller cohort groups, which will allow more interaction and application of the lessons learned. Today's webinar objective is to learn about the CHA Performance Excellence Framework, its purpose and categories, and understand the application of the framework to the state Flex program. And we have some great speakers today who will be providing us some examples at a local level from a critical access hospital administrator, and also from the Flex monitoring team in the Federal Office of Rural Health. And so we'll get a sense of the need for sustained critical access hospital turnaround and performance, and also be introduced to a case study that we'll be using in the applied learning during the webinar series. So today's agenda is we'll go through an outline of the Framing Rural Health Values series and all the great topics you'll be hearing about over the next couple of months in the series, an overview of the Performance Excellence Framework and how this really can help support healthcare transformation, and then they'll look at the relationship between performance excellence, the flex, and critical access hospital performance through a panel discussion. And on that panel, we'll have Christy Martinson from the Federal Office of Rural Health Policy, John Gale from the University of Southern Maine and Flex Monitoring Team, and Diane Banks, who's a Vice President from West Shore Hospital in Manistee, Michigan. And then we'll review our critical access hospital case study. And the webinar series structure, and I know you've all seen this through the brochure and the flyers we've demonstrated. After today's kickoff webinar, there are 5 more plenaries, and those are 1-hour webinars, and those will all be recorded. So if you're traveling or on vacation one of those days at a conference, you can pick up the content through the recording. We will have a series outcome and wrap-up event on August 11th, and that's in place of our usual Task 90 call. And then we'll have 3 application exercises, and if there are multiple folks from one state, you don't each need to submit this. You can have a group project. And these are not thesis papers. It'll probably take you 15 minutes to work through the application exercise, and after reviewing the case study, hospital, and focusing on the topic for that cohort discussion and flowing through the questions and making some recommendations. And with that exercise will be submitted via an online learning environment called Moodle. It's similar to Blackboard for those of you who maybe have taken an online course or taught one recently. And then we will have 3 cohort conversations with about 20 people per cohort. We offered 4 different times, and that first one is on begins June 3rd, and those will be in a webinar format through Adobe Connecto, so we can utilize some polling features and have a smaller group discussion. So why is performance excellence an important framework for the changing healthcare system? Well, our current business model reimburses providers, hospitals, and clinics by volume. So the more they do, the more money they make. And it's not that they're being greedy. That's how the system was created for Medicare reimbursement. And every system is perfectly designed to produce the outcomes it was designed to achieve. And so this has resulted in some unfavorable outcomes of high cost and lower quality and some poor patient satisfaction. But that is changing, as we all know, that the Institute of Healthcare Improvement and CMS have recommended a transformation into healthcare through the triple aim. And we're looking at 3 main areas: better health, approach through population health, better care, trying to increase the patient experience through higher quality and higher outcomes. And finally, then lower cost, or at least controlling that per capita cost of care. In the midst of this transformation, it really does make sense to take a systems approach because we're trying to change 3 big areas, and healthcare systems are so complex. Now, the future healthcare business model we're looking at is quality and service with population health and a reduction in cost, resulting in in higher value. And this is the new formula that we're seeing used by accountable care organizations, shared savings plans, and initiatives through consumer satisfaction, the community health needs assessment. So these are all coming together. So there is a potential for some calmer waters and really a life ring of value to save us from those storms of high cost and low quality and chronic disease. And within rural, there are reasons for optimism because the revenue stream of this future model is really tied to primary care providers, and that is the focus for critical access hospitals, having that core primary care providers. There's lower beneficiary costs for Medicare and rural. Critical access hospitals do have those reimbursement advantages currently for cost-based reimbursement, and also higher provider payments in health professional shortage areas. Rural can change more quickly. It's smaller. It's had to collaborate since the beginning. There are just fewer people to solve the problems, so they've taken sharing resources through healthcare in the past, and it is more community-based. And we do have the National Flex program that supports CAUSE to help with the transition. And it is a challenge crossing this shaky bridge. And you can start at the rock here is the current reality for CHs, as at least half of their reimbursement is based on reimbursement, mainly through Medicare and also the private payers. But now we're seeing that the mix is starting to change for critical access hospitals, that some states are moving their Medicaid services into an ACO model, and now even the private pays are going to pay per performance. And so it is moving that they're having to have one foot or one side on the volume-based and one side moving into the value-based reimbursement. And that isn't just for critical access hospitals. We're hearing even large health systems who are the pioneer ACOs or doing shared savings are saying you can't just one day on January 1st make the change. It's a transition where some of the patients' mix is in one payment model and one is the other, and you make that transition from fee-for-service. We do have some assumptions about the future, that payment rates will decline overall. The quality and efficiency will be rewarded in terms of higher payments and shared savings. Readmissions and low quality will be penalized, and that certainly population health will be factored into the reimbursement formula. And that the Baldrige Performance Excellence Framework is the model that we've used for this blueprint for rural hospitals in terms of performance excellence. And it's a systems management tool that really aligns that focus on quality and performance. And it was created in the actual award by the U.S. government in 1987 in the manufacturing area in response to the U.S. losing competitiveness. And the government saw that manufacturing needed to be leaner, more efficient to be competitive. And so they created this award and really strove to create recognition for organizations that have that high focus on quality and performance. And there are definitely returns on investment, as you can see in terms of the amount invested and the return on that investment. And healthcare was added as a new Baldrige criteria in 2002, and 20 million copies of that have been downloaded. Now, certainly, all the organizations following Performance Excellence Framework may not ever try to compete for the award, but the framework does present a holistic approach and is used. And it really supports healthcare results. From some of the healthcare Baldrige winners, they've seen mortality and patient safety errors drop by over 50%, patient satisfaction go up to be one of the highest rated providers for hospitals of similar size. It really supports a population health management goal and increased revenue, with one hospital seeing a 24% increase in their operating margin and 50% reduction in staff turnover through the adoption of the framework. And this is a illustration of the framework that we've modified from the Baldrige framework to illustrate the 7 components, but also to show that it's not linear, that it has to go in order and you can't move from one until you've completed the other. They relate to each other, and it's a very holistic model, but it allows for stronger focus on one component at times than another. And I'm just going to briefly go through the 7 components, and you will, over the next few months through the Flex webinar series, you'll be hearing about these components in more detail and hearing examples. For instance, next week on May 21st is the first webinar on leadership and strategic planning, and then we'll focus with one on workforce and on through. So I won't go into great detail, but just to highlight the 7 areas. The first one is leadership, and the reason we always do list that one first is because it's embedded so much into the others and is a leading component. And the key here is enhancing leadership awareness and alignment and capabilities. Then there's strategic planning, and the planning and the aligning of goals really moves an organization from just putting out the fires to looking at a vision-based organization, and to have strategy focused on quality. And then patients, partners, and communities, and this looks at how the organization engages its customers or patients, how it collaborates in the community, and how it listens to those partners and to the patients for improvement and for innovation. Measurement, feedback, and knowledge is an importance of looking at performance measures and evaluating process throughout all of the different systems in a healthcare organization. Workforce and culture, and the key here is developing that workforce capacity and a quality-focused, change-ready culture. And that is key to having high employee satisfaction relating to high patient satisfaction and moving to a patient-focused healthcare system. Operations and process, and this looks at the appropriate technology for quality improvement and having quality processes embedded throughout. And finally, impact and outcomes. And this is key to making sure that the organization calculates and benchmarks its impact, but also communicates that back to partners and customers and patients. So in a summary, the framework helps support the healthcare system in terms of starting with that leadership support, which is critical to helping rural hospitals stay relevant under health reform. And we do see all of you as Flex coordinators as leaders in rural health, and by supporting the rural hospital leaders. And this framework provides that support for a system-wide improvement. And again, it is flexible and can be used in multiple ways. And we're going to present a variety of examples over this series and delve into specifics in those 7 components. But starting with today, we'll be looking at how the Performance Excellence Framework can support the FLEX program overall and critical access hospitals. So first off, we're going to hear from Christy Martinson, and Christy is the Hospital State Division Director, and she's also the Interim FLEX Coordinator for the Federal Office of Rural Health Policy. And I'll turn it over to you, Christy.
Hi, thanks, Sally. I was just unmuting my phone. Good afternoon, everyone. First, I'd like to start off by just thanking TASC for putting together this great webinar series, for all the work that their team did, and then Mike McNeely and Dave Dietz from our team, too. I think you all know it wasn't our choice not to have in-person meetings. We understand and we appreciate, too, the value of getting to meet face-to-face, but unfortunately, this is just where we are right now. We can't have in-person grantee meetings within HHS as readily as we could in the past. So I think this is a really great alternative that tries to balance that sharing of information with also opportunities for more smaller group networking sessions. So I appreciate all the time that you'll put in over the next month just paying attention to the webinars, trying to stay as undistracted as possible as you listen in from your offices, and then really engaging in the activities and the cohort group discussions, because I think there's a lot that we can learn. And as you already heard from Sally, and as I'll talk about in my slides as well, this is really a good opportunity to think about how healthcare is changing and how we can really align our FLEX goals and the work that you all are doing with the critical access hospitals in your state to help hospitals through this really rough period of the transformation of the healthcare system. So I pulled these slides from some that Dave shared right before he left with the new orientation for the FLEX workshop. And it covers what Sally was talking about in terms of the national quality strategy and working around the 3 aims. And this is really what we've been trying to work for, incorporate our FLEX program into. And really, when we're going forward for the FY15 competitive grant, really aligning the work that we're doing with FLEX with the national quality strategy and these 3 aims, since this is where CMS is really building their strategy for their programs currently, and then all of the programs that they're designing around the ACA, they're using this national quality strategy and the 3 aims. So as we move forward with the FLEX program, we just want to make sure that we're aligned with where the rest of healthcare is going, so that the work that we're doing and that you all are doing in your states isn't trying to kind of compete with what hospitals are trying to focus on in a different direction, that we're all moving forward together. So other things to think about just in terms of the context and the performance excellence framework, as Sally mentioned, it is a period where there's just so much going on. So thinking about what is going on and what are the broad themes, what are the issues within your own states, what are your associations in your own states doing, or national associations that you need to start thinking about aligning with. CMS has the QIO program, and there's a new cycle that's beginning this summer. So it's really important to engage with those QIOs that are doing work in your state to figure out what their priorities are, and if there's ways that you can align with what they're doing through the FLEX work and use their initiatives to complement the work that you're doing through FLEX around quality. And then thinking too with the rural needs and what other national, both rural and urban healthcare needs there are, where is there overlap, and where can we align? So as I mentioned, these are the questions that we're going to be thinking about within our office as we design the FLEX program, and we really encourage you to think about it at your state level too, and engage in discussions with your project officers about where the challenges are within your state, so we know all the issues nationally, both national and at state levels going forward when we put together the next Flex guidance. So I know it's been a challenging few years as we've really made a lot of changes within the Flex program, and it's really kudos to all of you for being patient with us as we make these changes, move towards really building that evidence base. And I think we've come so far in the past 4 years, and we're really well set up, I think, to move forward with the FY15 guidance. And I hope you all can look back over the last 4 years as you're working on your Flex applications and filling out that evaluation section, thinking about where you've come, where you still see the needs are, and where your program might be able to help meet those needs going forward with Flex. Quality improvement, one of those 3 aims, and is a huge part of what we've been doing with Flex through MBQIP. Again, where we're going with MBQIP, fortunately this year we have a little break for no new measures coming on in September this year, so it's really a chance to think about how we can use the Flex dollars to engage in quality improvement initiatives, and that's something that we'll be working on to better provide information about nationally where we're going with that, and then specific programs that you can think about implementing in your states if you're still trying to think about ways to engage in quality improvement activities for MBQIP. We also have a lot of data that we've been collecting with the variety of activities that you've been putting together in your states. So we'll have the first round of PIMS data that you're submitting at the end of this month, and then we'll be able to look at that and just see where everyone is, what activities they're working on. And then with the next round of data coming in next fall through PIMS, really see what's working, what's not, use that PIMS data to share best practices across states, and then think about what are the interventions that really make sense for Flex, and are there any that we might need to think about whether or not to include in the program going forward. And of course, understanding that there's always unique methods that states are working on. So there is, a need for some flexibility, and each state has their own models and their own set of partners, so things are going to look a little bit different in each state just depending on what resources are available and existing programs already in place. So that's kind of where we are now, and looking forward, we're just trying to work through some of these challenges so that when we do put the guidance together, we'll be able to have a clearer structure and a clearer path forward for the Flex program that will hopefully make your jobs as Flex coordinators a little bit easier. I think one of the big things to start thinking about is just the idea that the Flex program is not enough funding to be able to support all the needs that you have within your state. So figuring out how you'll be able to prioritize where the Flex dollars can have the most impact, understanding how to keep engaging those high performers in your state, the critical access hospitals that really get it and can be kind of mentors to other critical access hospitals in your state. And then, some hospitals just maybe don't have an interest in participating, or they just have too many other issues going on. So figuring out how to work with those hospitals as much as you can to figure out how to best target those Flex dollars to drive improvement within the 3 core areas of Flex in your state. And again, we're, especially with MBQIP, working at our level nationally to partner up with CMS and make sure that where we're going with MBQIP is in line with what CMS is doing and what their priorities are to make it a little bit smoother the next time around. So again, for thinking about the FY15 guidance, continuing on the path that we've been going of having a clear set of interventions, being able to really measure quantitatively the outcomes of those interventions, figuring out how we can expand partnerships both at the national level and within the state to really leverage the Flex dollars to have as strong of an impact as we can to help these critical access hospitals and help support them as they're working through the challenges of the changing health system. And then hopefully at the end of the FY15 grant cycle, the 3 years in 2018, we'll be able to look back and really be able to tell a clear story of where we've come from and where we'll be. So I just wanted to highlight from the performance excellence framework that Sally shared a few minutes ago, how this ties into what you're doing at the Flex coordinator level, so your work at the state level. Since the blueprint is framed in a way that it's for hospitals, I just wanted to talk briefly about how you can think about it from the Flex coordinator position as well. And we're also going to be thinking about it from ORHP as well, and our work with HSC, our work with the Flex program, for how we can integrate these aspects into our planning here. So, strategic planning, that's thinking about your work plan. As we're headed into the FY15 guidance, you'll have the opportunity to set the stage for the 3 years of your project period. So laying out the work, not just for 1 year, but how you're going to address the needs within your states over the 3-year period, linking the activities and initiatives together over that 3-year period. For workforce, thinking about what are the staffing needs that you have to meet those goals. Are there experts that you need to reach out with? If you don't have expertise within your office, are there partners in the states or consultants that you can work with that can help fill in that gap if you don't have it within your office? Impact and outcomes, just continuing to think about your program as a whole, evaluating it, seeing what's working, seeing what's not, making changes as needed. For process for improved outcomes, thinking about what are the interventions and activities that really do make a difference, looking to see what best practices are out there, looking to see what reports FMT has put together that provide information about best practices, working with task, calling partners in other states and seeing what they're doing that works. And as part of that, for the measurement, feedback, and knowledge management, the virtual knowledge groups are a great way for sharing information real time and hearing what states are doing. And then from our office perspective, we're going to be, as I mentioned, looking at the PIM system and using that nationwide roll-up data to see how that informs what we're doing with the Flex program and how we can change it. Needs assessment is also a key thing to consider as you're implementing your Flex program, to see what is it that your hospitals say that they need. Where are there issues in terms of kind of county health data where there might be some areas that critical access hospitals should be looking into within your state. So making sure that you're looking at the data of your critical access hospitals. The FMT has some good cost report data, which I know is a little bit outdated, but it is great trend information just to get a snapshot of the trends of hospitals within your state. And then they have the quality reports as well, or in BQIP, you can look at the data to see where there might be areas of need to potentially fund interventions. And then, as Sally mentioned, leadership is kind of the key piece of all of this, so making sure that you're engaged in educational events, using TASK and all the resources that they provide, finding out what other resources there are within your state to educate yourselves about what's going on, but keeping up with what's going on in terms of the Flex grant itself and then all of these policy changes so that you know where things are headed within your state and can align your Flex program as well. So thank you again for your time today and over the next few months, and we look forward to hearing from you in all of the discussion sessions. And I guess now turning it over to John Gale, who's a part of the Flex monitoring team from the Maine Rural Health Research Center.
Thanks, Christy. What I want to do, and I don't have a lot of slides, but what I wanted to do is give you some of our perspectives on using a performance excellence framework, both from the perspective of critical access hospitals and state Flex programs. And it becomes critical. So much of performance excellence, and we talk a lot about the move to a value performance and reimbursement system in the future, and that is true, but I sometimes feel that we're a little bit like the coyote in the old Roadrunner cartoons, where he is standing on the dock and he's got one toe on the transom of a boat with a little sign that says, "Oh no," and we're trying to get from one place to another without falling in the water. And I think, from my perspective, that this is a critical time, because not only are we moving towards a new system of compensation, maybe take a little longer than we all might hope, but we're at a point where I think hospitals also need to understand that they have to document and demonstrate their value to their communities. So many hospitals that are struggling nowadays, and there are a number of critical access hospitals that are struggling, if you look at their volume, people go elsewhere for services. There's a perception that because they're a local hospital, they may not be as good as a bigger facility some miles down the road. And so all of this framework is important to not only documenting and communicating your value to the community at the moment in terms of soliciting and encouraging use and support of the hospital even under the current environment, but it becomes increasingly necessary as we move forward to the new reimbursement world. And so I think that's what I'd like to talk to you a little bit about today. And let me see if I can move these. So the importance of a performance excellent framework for critical access hospitals. And I've mentioned so many hospitals are struggling with volume. There are plenty of resources. Folks are not particularly those with the resources that can either travel or use other facilities, are not adverse to leaving the community for health services. So if you want to keep people about, you need to really think about that value. In our work, and what we're currently doing now is some work that we've had on hospital turnarounds, and we've interviewed a number of hospitals and really talked to them about what drove their crisis and what strategies have been helpful in moving them away from closure towards financial success and viability. And what not surprising is that hospitals rarely struggle with just one issue. It's not cost, and it's not volume, and it's not quality alone. That so many of these issues are wrapped up into, there are multiple issues that a hospital has to deal with. And so there's a need for, I think, a demonstrated, comprehensive performance improvement strategy. A hospital that is not, or at least if there's a perception within the community of poor quality, or a perception within the community of the hospital is struggling financially, that's going to influence community use and community perceptions, patient use and perceptions. And even if you're doing a good job on those things, that perception can still dog a hospital. So there's a need to have a framework that is really sort of well accepted and can move hospitals and can be used to communicate success. I know that Terry and Sally and Task and others in the Office of Rural Health Policy and within the rural world have looked at balanced scorecards in the past. And the importance of balanced scorecard was that it really encouraged organizations to think across the four domains, that you couldn't fix one problem at a time or to the exclusion of others, that there needed to be a balanced approach. And as I've looked at the Baldrige excellence criteria, I mean, it's very consistent. You're looking at leadership and some of the keys to the hospital turnaround, which are driving dynamic leadership, having a strategic plan, leveraging community support, reducing costs, developing revenue opportunities, managing the revenue cycle, certainly improving quality of services and quality of care, and improving customer satisfaction, reducing staff turnover, promoting hospital and physician alignment, and collaborating and entering into partnerships. These are, a wide range of strategies, much of which, and almost without exception, are reflected in the Baldrige framework. And as you move forward, if the hospital moves forward and works with in each of these areas and has success in improving quality and improving patient satisfaction, this gives you a recognized framework and context for communicating that performance. So often the hospitals don't have a clear way of reaching out, and communicating to their key stakeholders what they're doing. And having something like Baldrige or some of the other performance excellence frameworks is critical, because it gives you something that is recognized from the outside. And to many people, not even in healthcare or management, folks know what the Baldrige name has some meaning. And let's see if I can do this. Excuse me. Oops. Here we go. There we go. And in thinking about this, if you move forward, what's important in across Flex programs is we've all seen, you all have more hospitals and more issues to work with than funding. That's a reality of our environment. So using a performance excellence framework across hospitals gives you consistent data on what your hospitals are doing. And then that can really be a helpful process of identifying and developing appropriate interventions. If you have hospitals using and reporting according to a performance excellence framework, and you can access that data, you can access their community needs assessments, do some of your own need assessment work, you can then begin to develop appropriate interventions to address the priorities. You can also begin to address interventions to take advantage of economies of scale. Going back some years ago to the early days of the Flex program, I think Wisconsin had done some really interesting work with identifying sort of key consultants, key interventions that hospitals could buy into and they could take advantage of. But the whole goal was not to have individual personalized interventions that from hospital to hospital, but to create some consistent opportunities that could be used across multiple hospitals. And to me, this is a very critical piece of using a framework, that it gives you that ability to target what are the big issues. Is it a revenue cycle management? Are your hospitals not collecting the money they need to? Is it your pricing structure and your I'm drawing a blank on the name now, the charts, I'll even skip it because it won't come to mind. But I'm sorry, but looking at pricing, is it about quality? Is there a consistent quality issue? Is it a communication issue? But it gives you the opportunity to pick up on strategies that can be applied to multiple hospitals and take advantage of both group learning and spreading the use of a tool and resources across multiple facilities. It also lets you communicate then back to the office, through the monitoring team, and through state reports, just what the impact of the Flex program is. If you can take advantage of that and show how Flex initiatives are impacting hospitals at both a hospital but at a state level, it gives you more ammunition to move forward. And so it's, I think, a very critical framework. Going back to another sort of standard that I've worked with and looked at it in the past, and this is a financial group out of the Midwest called Larson & Allen, and they've had what they've considered their gold standard performance, and I think they've worked in Iowa and they worked in other states. But along with Baldrige and others, it just sort of makes the case that for a hospital to have gold standard performance, they have to manage costs. They have to have strong procedural and ancillary services. They have to have quality. They have to have outstanding relationships with their physicians, and having good physicians. Physicians drive your utilization, hospital utilization. There's aggressive growth and expense management both. It doesn't do you a lot of good to expand business aggressively if your costs are out of control, and it's not a case where you can lose $1 per service but make it up in volume and then obviously sufficient revenue. So, again, from our perspective, and looking at hospitals that have been struggling and then looking at how to target and improve the work of not only the hospital state flex program, but performance excellence framework just makes perfect sense to us. And finally, I'm going to talk a little bit and then turn over the presentation about for an example of an initiative that has done some of these same things, not working specifically with Baldrige, but through the 4 New England states with critical access hospitals, they've developed a New England-wide performance improvement collaborative. They call it NEPI. It's conducted through the 4 New England states with CAHs, Maine, New Hampshire, Vermont, Massachusetts. And they've gotten together under the rubric of the New England Rural Health Roundtable, which is our region-wide rural health association, to develop initiatives across the states. So one of the first things that they did was to fund a report partially with flex dollars and other state monies that identified a core set of rural relevant measures. They were that would be used and reported by the hospitals in the network. So they were widely adopted, they were early relevant, and they reflected a consistent balanced scorecard approach. And as an example of a couple of the projects they've done, they worked with the Institute for Healthcare Improvement and their HCAPS project. They tracked and monitored performance, but it was really to assist their participating hospitals with understanding the best practices for patient engagement and satisfaction. They developed a governance portal, which is a web-based training tool for hospital board members, looking at a variety of modules, many of which were, I think, almost exclusively reflect the performance excellence criteria in Baldrige. And finally, they used that to really share lessons and improvement and success across the 4 participating states. So that kind of a framework, to me, just was a very, very successful initiative. And certainly the 4 states that are participating are continuing to fund and work with that collaborative. And I think that finishes my section of the presentation. I think it's turning it over to Diane now.
Yes, thank you, John.
You're welcome.
And our next speaker is Diane Banks, and Diane is the Vice President of Performance Improvement from Manistee, Michigan at West Shore Medical Center, and became highly recommended for a good best practice of using a performance excellence framework. Diane?
Hi, everyone. It's very nice to be here today working with you, and I just want to thank you for inviting me and giving me this opportunity to share the work we're doing at West Shore using the Baldrige framework to improve performance. I have only one slide, and other than the picture of our hospital, and it'll be coming up next. I've developed a tool that we used to present the Baldrige framework to our board and our executives. And I think if you could show that tool now. There we go. And it basically is a picture of the framework in a very simplistic way. So I'm just going to walk you through it. And when I walk you through it, you'll see how we used it to accomplish many things here. So we went out on a strategic planning retreat in January. I took our executive team members, some key managers across the system, and board members out on a retreat. And we looked at revamping our mission and our vision and our values because that's key in the organizational profile of Baldrige, to make sure that you have that done well. Basically, our current mission today is providing quality care close to home. We're a small rural hospital. We are in Northwest Michigan, and we have been a critical access hospital in the past. We are no longer a critical access hospital, but we are still a small community hospital. So our mission, the reason we exist today, is providing quality care close to home. Our vision, which is over here, is to become the healthcare provider of choice in the greater Manistee area. So we know that we are not the healthcare provider of choice now because we have about 60% of our market share. About 40% of our market share goes someplace else. So there's a gap between where we are today, our mission, and our vision. And this whole Baldrige framework is about closing that gap between where you are and where you want to be. So it's a very future-focused model. There's a journey that you have to go through, and your values, which are here in the middle, are things that you have to be really firm on and clear about because they guide your decisions along that journey, and they will keep you on course. So all the decisions that you make in strategic planning or running your enterprise really has to be run through the filter of your values. And our values are compassionate care, commitment to community, teamwork and collaboration, excellence every day, and stewardship. So those are the 5 things that keep us on course. So now we know where we want to be. We want to have at least 80% of the market in the next 3 years. And we have to do that in order to stay viable as an organization. And we had to take a long, hard look at everything we do here and evaluate every service. And we realized that, you know, we can't be everything to everyone. We can't be everything, but we have to focus on what we do well. And we have to not do things that we don't do well, do more of what we do well. The 3 things that we realized we had to do are strategic imperatives. In order to close this gap, where we had to focus on quality and safety, that's our first strategic imperative. We had to focus on the patient experience, that's our second strategic imperative. And then we had to focus on improving access. When we were a critical access hospital, we were bound to our campus. And when we became an acute care hospital, we had a little bit more flexibility in terms of where we could establish services. And so we are using that flexibility to increase access. So the course of how you use the grid. So that was the first thing we had to do, was revisit our mission. Why do we exist today? Where do we want to be tomorrow? Be firm and clear about our values. And then we had to establish, I usually tell organizations 3 to 5 strategic imperatives, no more than 5, because you really can't do everything. So I'll just walk you through how this grid works and how we populated it. So right now, this document is about 10 pages long because every one of these little squares has things in it. Basically, the role of leadership is to communicate why quality and safety are an imperative. That it is to set expectations and accountability. It's to provide resources. It's to adhere to state and regulation, and it's really to be good stewards. It's to be good citizens, and it's to create an environment for engaging and learning. So basically, that's what that leaders need to do. That's the message they need to impart around quality and safety. And we just put the key talking points in this box here on what leaders would be saying, and that message would reverberate in every opportunity for them to communicate around this imperative. Then we went to work developing specific plans for quality and safety. And our strategic plan for quality and safety is really about being the best we can be on our core measures, on our value-based purchasing, on our pay-for-performance measures with Blue Cross and Blue Shield, and on our national patient safety goals. So that's really what our plan is. And so we really are looking at what we have to do to improve our performance on those measures and to achieve those national patient safety goals. And there's a little line right here where we, in the course of identifying the plans, we had to estimate how much it's going to cost. What are we going to have to invest in order to support the activities to achieve those goals? You have to look at who your customers are of each one of those activities. In this case, it's CMS, it's the Joint Commission, it's Blue Cross Blue Shield, it's Priority Health, and you have to look at who your customers are, how you communicate with them, how you listen to them, how you learn from them, and how you design your systems and processes in order to meet their expectations. And so you really have to have a strategy for listening and learning to customers and designing and developing your processes around meeting their expectations. The next category is for quality and safety for us has to do with information and analysis. And this is really one of the easier ones because most of the information, most of the benchmarks are provided for us on hospitalcompare.gov and HCAHPS on the Joint Commission. So we have the goals we have to meet. Blue Cross Blue Shield and Priority Health establishes the threshold performance that we have to meet. So but internally we have to develop a data collection system to make sure that we know we are achieving those goals. If we're not achieving those goals, we need to know immediately that we're not achieving those goals so we can course correct and get back on course. This category is all about collecting strategically significant data, turning that data into information by analyzing it over time, by stratifying it, by aggregating it, by comparing yourself to others. Once you have information, data becomes information when it can inform you. So once you have information, you're informed, you then have knowledge, and you can take action, and you can improve results. And that's really what this category is all about. The next category is the workforce focus, and that really has to do with, for each one of these activities that we're going to do here to improve quality and safety, how many people are we going to need? How many abstractors are we going to need? How many people in IS are we going to need to develop order sets to collect the data that we need to know that we're meeting our core measures and we're capturing all the documentation, the required documentation that we need? So what is the staff that we're going to need in IS? What are the staff that we're going to need in PI? What training are they going to need? How are we going to get them? How are we going to train them? How are we going to keep them? So that's really what that is all about. And you have to have a plan for each one of those things in order to achieve that goal. When you get to operations focus, it's what processes need to be functioning well in order to achieve those goals. You know, we have new core measures now on stroke. So do we need a process improvement team on stroke? Does that team need to be facilitated? Do they know what the PI process is here at West Shore Medical Center. What other processes, our discharge planning process to meet our readmission measures, how well functioning is our discharge planning process. So you have to look at all the processes that have to function well to support the achievement of these goals. And how do you design those processes? How do you improve those processes? How do you manage those processes? And then finally, the results category is when we were back in strategic planning, we set targets that we wanted to achieve. In information and analysis, we report on the achievement of those targets. And then in the results category, this is what really comprises our scorecard. And we have scorecards at 3 different places in the organization, and they're all congruent. So we have a corporate scorecard that has all these critical measures on it. And we have a scorecard for each department in the hospital, which is congruent with the corporate scorecard. And then each medical staff committee or section has a scorecard to make sure that it is congruent with the corporate scorecard. So we have these scorecards at 3 different levels in the organization. I'll just move on to the second is patient experience. So our second strategic imperative is patient experience. That's all about HCAHPS for us. And so again, the leaders have to communicate why that's important, state expectations around patient experience, hold people accountable, provide resources where resources are needed. We have to have plans. We are establishing a listening and learning forum for our patients, patient experience councils. We're looking at bedside interdisciplinary team meetings. We're looking at bedside report. We're redoing our wayfinding. So we're doing lots of things, activities. That's on our plan to improve the patient experience. Some of those will be costly. The wayfinding initiative is costly, so we have to make sure we budget for that. We have to also be in touch with our customers. We have to listen and learn. We use HealthStream to collect our patient satisfaction data. And so we have a constant stream of data. The voice of the customer is coming in. We're listening, we're learning, we're adapting, we're managing our processes, and we're actually, the voice of our customer is reflected in our plans. They tell us what needs to be improved here. Again, measurement and information is, we rely mostly upon HCAHPS, but we also have to drill down in the listening and learning to the customers, in the patient advisory councils, the focus group, however you listen to your customers. You need to quantify what they expect. So often in our patient satisfaction data, we have a set of canned questions that everyone asks the patients, but those questions sometimes aren't important to the patient. You really have to figure out what's important to the patient, what their expectations are, and then measure your performance against what they expect and what's important to them in order to improve the patient experience. In terms of workforce focus, if we want to improve service, what training do we need to do for our staff? How do we model our behaviors? You really have to look at those values that are up on the top of the page. How do you live those values? How do you reinforce those values in everything you do? Your values should not be framed on the wall. They should be in the performance of your people. So that you should be able to see your values in the way your patients and your people interact. In terms of operations, we have to look at, again, processes. What processes have to be in place? We're doing SBAR for transitions of care. We're doing ticket to ride for handoffs from department to department. Just looking at, again, bedside interdisciplinary team meetings, bedside report. What processes do we have that satisfy patients? We need to do more of that. And what processes do our patients find cumbersome and dissatisfying? satisfying. We need to do less of that. So it's about listening and learning and designing, managing, and improving processes according to patient requirements. And again, that is what comprises our balanced scorecards. Finally, with access, we, as I mentioned, now can move off campus. So we're doing much more outreach into the community. So that's a big change for us. We've been a small community hospital, and we've been bound to our campus. But when we looked at our balance sheet, 80% of our revenue was from outpatient services, and 20% of our revenue was from inpatient services. If you look at healthcare reform, the future is not in maintaining inpatient services. We know we will always maintain an inpatient presence for our community, but the growth and survival for us is going to have to be in outreach, in collaborating across the community, and in really doing much more on an outpatient basis. So we have to put the plans together for that. One of the things we'll be doing, one of our strategic initiatives, is to develop a walk-in clinic. We'll be doing that this summer. We want to develop more wound care. We want to have more outreach in areas around our hospital. In terms of we have to, again, allocate dollars to do that. This is probably the biggest ticket items are down in this imperative in terms of establishing new services. And basically the customer focus is, who are the customers in this new market? What is the market? What do they have to say? If they go someplace else, why do they go someplace else? What can we, if they're going someplace else, how can we offer here what they travel for so that they don't have to go someplace else and they can get it here? How do they even know what we have? It's so amazing to me that we have customers drive by the hospital and drive 60 miles to go for a test that we could do right here, simply because they don't know that we have it. So that, that will help inform our marketing plan. Measurement and analysis. We have to look at customer satisfaction on those new services very carefully. We have to look at a return on investment. We have to look at our pro forma, what we expect, and are we anticipating, are we actually realizing the return that we expect. In terms of workforce, what kind of people are we going to staff that walk-in clinic with? Are we going to have nurse practitioners? Are we going to have physicians? What are the hours going to be? How are we going to promote it? What's the regulatory environment? How are we going to get the people? How are we going to train the people? How are we going to keep the people? Those are the three big questions. In processes, what's our scheduling process like? What's our marketing process like? What's our registration process like? Are we going to create new processes? Are we going to go with hospital processes and try to retrofit them in the community? What information system are we going to need? And again, all that reflects on the balanced scorecard. This is hard to read because this is a small font, but I really want to draw your attention to the bottom row, because the bottom row, you get a lot of bang for your buck out of this framework. If you look, let's just look vertically at leadership. Everything that is being communicated that's strategically significant comprises the communication plan. Everything that is in the strategic planning column comprises the strategic plan and feeds the budget. The next is your customer service, your customer focus, everything that you've written in this vertically here. This is your customer service ethic and your customer service plan. The next one is your performance improvement plan and your information flow plan. How do you report? How do you keep everybody informed of how well you're doing or not doing in order to improve? This next column under workforce focus feeds your human resource plan. So if these are your strategic imperatives, and if you're going to be hiring people and putting your scarce dollars toward recruiting and hiring new people, then you want to plan for that. And it also feeds your budget. And then finally, this operations focus feeds your PI plan and your facility plan. So you're not doing musical chairs with physicians' offices as you're adding and recruiting, and then basically, you know, this last column feeds your corporate scorecards, and for us, it's our departmental scorecards and it's our medical staff scorecards. So when you're finished with this, while it's not a small amount of work to take the time to do this, you get a big return from this. So that's the approach that we take. I developed this tool to help the performance excellence framework be explained simply to people that I really needed to grasp it. It is the Baldrige purist probably won't like it because it's not, you know, that cheeseburger model that we're all used to looking at, but it's a tool that is very functional and it works for us. So I've got more to say, but I don't know how much you want to know, so I guess I'll just stop talking there.
Well, great. Thank you, Diane. This is a really good application of the Performance Excellence Grid, and you had shared with us as we were talking about the call that the need for this when you lost your CH status and needing to make a quick turnaround. So we appreciate that, and we'll hear more from Diane in a series of questions where we'll be asking the panel, Christy and John and Diane. So now you can see them all up there on the screen. And we are going to work through some questions, and then we'll open it up to all of you to ask either on the phone or through the chat box. So the first question for the panel is, why should Flex programs use a performance excellence framework? Maybe I'll start with Christy on that one. And star 2 to unmute.
Okay, thanks, Sally. Yeah, I think, first of all, thanks to John and Diane for their presentations. And Diane, this performance excellence grid that you shared is really good. It really simplifies, I think, where we can go with it. So as we talked about on this call so far, there's just so much going on with the changing healthcare systems, this period of change that we're in right now where we're still getting paid under the current system and we're moving towards a new system that focuses more on paying for value. And that counterbalanced with the fact that the Flex program just doesn't have enough money in it to fund all of the need that there is out there. So I think this performance excellence framework really provides a mechanism to think about what are the key priorities within your state and how can you target your resources and your dollars to really focus on those priorities that you have identified in your state to kind of keep you on track with where your vision is and not get sidetracked by all the other things that come up on a day-to-day basis. And I know, speaking for myself within our own office too, I think this is something that can help us really focus our energies on where they need to be focused, because every day there's something else that comes up that can kind of sidetrack us.
Thank you, Christy. This next question we'll pose to Diane is, why should critical access hospitals use the performance excellence framework?
I think the reason the framework is so important is it helps you with alignment. We can no longer be everything to everyone. We have to focus on what we do well. The framework enables us to focus and then stay on track. So we're constantly reminding ourselves what business we're in, what we're here to do, what we're trying to achieve. The other thing that few people talk about is that your board members from business and industry are really familiar with Baldrige, and they get it. And so frequently, you might be in a situation where your board members know more about Baldrige than your CEO, because Baldrige has been embraced since the 1980s by many businesses and industries, especially manufacturing and service industries. So if you have board members from those areas, they're very, very supportive, and really understand this framework. So it's easy to get the board on board with this.
And with this one, John, for you, what changes and outcomes have you seen in critical access hospitals using a framework?
Well, I think the consistency of dealing with a complex set of issues across the board. I think it provides a structure and a framework. Christy was right. I mean, we're all besieged with change and new things day to day, and it's easy to get distracted with things that don't make as much of a difference. So to me, having a consistent framework, and what I've seen with hospitals has been able to make real change in their value, in their performance, is that they have a framework and a plan, and they stick to it, and they work that plan. And that provides, I think, a discipline and a structure that is very, very critical. There looks like there's a question, if I could take a half a second too, from Stephanie in Idaho, is asking about how the logic model and the Baldrige framework fits together. You want me to take that now or wait for a bit?
Go ahead, John.
Okay. Well, I think the logic model is a tool to think about how you apply the aspects, the different components of a performance excellence framework. One of the things that we've seen in our case studies with hospitals that have been struggling to turn around their fortunes is that there are some common issues, but the extent to which those issues may be more or less important from hospital to hospital varies. And so what I think is important about the logic model is it's a way of thinking about what the needs of the hospital are, what the common problems, or any problem or any program. Thinking about what the common problems are that you're trying to address and mapping out a plan to get there. So some of the outcomes from, say, the Baldrige framework and the criteria they're looking at make perfect sense. So at the end of the day, you're trying to influence those things, but the logic model can help you think about the problems you're solving, defining the problems, so you're all starting from a consistent place. Then what are the resources that you have, and what are the interventions and the priority interventions that you're going to implement to make change? So I think the logic model can be an important part of the planning process for thinking about implementing a performance excellence framework or a Baldrige framework.
Stephanie, this is John John, this is Stephanie from Idaho. Sorry about that. Sorry, I couldn't unmute. So you're thinking that the logic model would be then a tool to use inside of the framework?
Yes.
As part of the strategic planning process?
Yes.
Okay. Thank you very much for clarifying that. I appreciate it.
You're welcome.
Thanks, John. Well, as we're noting here, frameworks can be overwhelming, and you need tools to help implement it. So how does a small flex program or a CH implement a framework? We'll start with Diane in terms of a smaller hospital and how you undertook the implementation.
Well, I think it's challenging because small hospitals don't have a very deep bench, and you usually have leaders where everyone does everything. So we don't have the resources that larger systems do. But we also are used to working together. We're usually pretty high-functioning teams. So I think as a former Baldrige examiner, when you examine a hospital, they can be at different levels. They can be at a very early level of Baldrige performance, or they can be a very mature level of Baldrige performance. I think it is unrealistic to expect a small hospital to put together the Baldrige framework and have it perfect. It's really a long-term commitment. It's not a quick fix, but you have to start. And if you can't do everything, just do something. Maybe you just want to take one strategic imperative and work it through. But I think that you just have to start it And it's important to get your board on board. It's important to get your leaders really understanding that it's not a quick fix. It's a long-term commitment, but it has demonstrated results in terms of survival of organizations and just getting realizing the vision.
Thank you. And then John or Christy, suggestions for how a smaller flex program with only 1 or 2 staff could approach the performance excellence framework?
Sure, I'll take a quick cut at it, then let Christy respond too. And I think Diane hit it on the head. You can't let perfect be the enemy of the good. So start small, scale the program. You know, if you read the literature on Baldrige or balanced scorecards or any number of the different frameworks that are out there, there's a real pressure from some of the folks that have developed them to maintain some fidelity with the way they do it. And I'm not sure that's always necessary. I think Diane's right. If you scale it to your own size, to your own needs, make it work for you, you don't have to do it exactly the way someone else might. But again, I think the key is having a framework around your issues and around your activities that so you can manage them.
Yeah, I agree with John. It's thinking about how you can take this and use it to think holistically about what you're doing, and just start small and see how it works and adapt it as you need to meet your needs. But this is a great way to start because it forces you to walk through all the different components of an activity and really think about each thing and design your program more holistically.
Thanks, Christy. And we had a question, Diane, for you in the chat box of explaining the Baldrige examiner that you mentioned.
National Baldrige Quality Award trains examiners every year. So this is done through the department. I'm sorry, it's the National Institute for Standards and Technology. They oversee the Baldrige Award. And you can apply to be an examiner, and you can go there. It is a volunteer position, so you're not paid to be an examiner. I was an examiner for 5 years. And basically, as an examiner, I volunteered to review applications of companies that applied for the awards. And it was a wonderful, wonderful experience. It's very time-consuming. So you generally work with a team of other examiners to examine a company who has applied. You come to consensus, and then a panel of judges determine who wins the award. What you learn as an examiner is that there is no one right way to do this, that each organization figures out what's right for them. And, but they follow the criteria. The criteria are not prescriptive. They are simply the criteria, and each organization determines how to meet them. So it's, I would encourage anyone out there who's interested to apply for and become an examiner if you're interested.
And there are state Baldrige or performance excellence organizations, Carol, and I know we connected with the one here in Minnesota, and they provided quite a bit of information and background for our staff as we were implementing the performance excellence blueprint for critical access hospitals. So they're a great resource and they explain that process.
And the Michigan State, it's called the Michigan Quality Leadership Award. I was an examiner there for a year before I was a national examiner, and they emulate the national program almost exactly, and that's a wonderful, another wonderful place to learn in your state award programs.
Thanks, Diane. And just our final question was, how is the performance excellence framework help support the changing healthcare system? And maybe Diane, I'll start with you on that one.
Well, you know, the healthcare reform is really about providing the right place for care at the right time in the right place. It's about collaborating across the community. the more of us that are using the framework, the more of us that are speaking the language, get the process, the easier it'll be for us to collaborate and deliver health care in the most appropriate place. So I think, of course, the performance improvement and analytic part of it really will help us with population management and population health, improving the health of our population, and looking at the aggregate and then stratifying it. So I think it's the more of us that do it, the better.
John or Christy, any comment on that question?
Well, I think one of the things also to think about, and it's a point that I had meant to make earlier, if you think about where hospitals are now and then their need to move to a value-based performance system, you're thinking about joining an ACO, or there are third-party payers, insurance companies recruiting panels and making decisions about who's in and who's out of the panel. One of the best ways to be of value and be an attractive dance partner when it comes to that process is to have a good group of patients that support your facilities. So if it's awfully hard to make a case that you're a key provider if you have very low utilization. So using something like Baldrige or another performance excellence framework to sort of turn your fortunes around, encourage utilization, and communicate that value to people who are looking to move to the next level of reimbursement in the system is, I think, a critical current task for hospitals to undertake.
Great.
And just to tie it back to the flex core areas, you know, what John was saying, hospitals need to think about where they are within their community. And so that's being able to tell their own story about the quality of care that they're providing. So quality measurement and improvement is a key part of that, so for core area 1. And then they have to understand about their finances and what their payment structure is now, where they're, how they're getting paid for their services, what is the volume of services that they provide and the different activities, outpatient versus inpatient, and then understanding who their patient community is and if that is going to change their payment in the future depending on who's going to be insured or not, what the age of their population is. So being able to tell that financial story, so core area 2. And then I think both Diane and John have talked about the importance of market share and the hospital understanding what the needs are within their community, what services they should be providing or shouldn't be, and looking at population health and how they can best serve the needs of their community and partner up with other providers to provide that right care at the right time if they're the right place. So for core area 3 as well.
Great, wonderful. Thank you, Christy. So the next event is Wednesday, May 21st from 2 to 3. So the next webinar is only 1 hour, and that one will be on leadership and planning. And I think there's a question about will the slides be available, and yes, they will be posted along with the recording following each webinar. And then we will be posting this case study in the Moodle environment. So once you registered and you received confirmation of being set up in the Moodle open source format for the cohort, and we can also post this case study along with the slides so you can read through it. But we'll be studying this Community Memorial Hospital, which is on the verge of closure and desperately needs a flex program intervention in many ways. So we'll have 3 short exercises, and you'll be able to post your recommendations, and then we'll discuss those on the cohort calls, with the first one starting in June. So we'll post that exercise next Wednesday and explain it at the end of the call. So you have a few weeks to get